Hello, everyone, and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. My name is Jenna Morton. I'm one of your 3 co-hosts for this series, presented on behalf of the Canadian Premature Babies Foundation. I'm a career broadcast journalist and mom to 3 NICU grads, including preemie twins who were born at 32 weeks and are now 11 years old. I live and work in Mi'kma'ki outside of Moncton, New Brunswick. Thank you for joining us today for Preemie Chats. Preemie Chats, of course, is a creation of the Canadian Premature Babies Foundation. You can see our website there on your screen, canadianpreemies.org. The foundation is a parent-led charity that helps families during and after their NICU time through education, support, and advocacy. I hope that you will take some time after this presentation to visit the website. You will find all kinds of incredible resources for all stages of your journey. Whether you are a parent or a professional, you're going to find a community that is working together to help our children thrive. And of course, this is very much a parent-led foundation and a community-based approach. So we would love to know where you're joining us from today, what brings you to us, whether you are a parent or a family member, a healthcare provider, a caregiver. Please let us know where you're joining from and what brings you to us today. And as we go through today's presentation, which I know you're going to find so much information from and so much is going to resonate with you. If you have stories to share, if you have questions for our guests, please feel free to drop them in the comments and we'll do our best at the end of today's presentation to address some of those. Well, today's presentation is definitely one that is going to resonate with parents of preemies. I think it's probably sounds like a bit of common sense to say that parents' perspectives are fundamentally important in shaping how we approach and care for preemies. But until recently, a lot of the information that was studied and gathered about preterm infants was directed by what scientists wanted to know and the questions they were asking. And those questions and the answers they were finding weren't necessarily what parents were wondering about and wondering what would lie ahead in the future for their preemies. Well, the Parents' Voices Project is something that aimed to change that. It's an initiative that starts with asking families of extremely preterm babies what they want to know and then seeking out those answers through scientific study. And today we're going to dive into what that project is all about and what it's learning and sharing with us. And to do that, we're going to be joined by 2 special guests who have a presentation for us. Pediatrician Dr. Thuy Mai Luu is a medical director at Saint-Justin Neonatal Follow-Up Program in Montreal. She's also an associate clinical professor of pediatrics, a research scholar with the Quebec Health Research Funds, and director of the Canadian Neonatal Follow-Up Network. And she's going to be joined by Rebecca Pearce, who is an educator, a researcher, and a preemie parent. Rebecca has co-authored several papers on prematurity from a parent viewpoint. She's an advocate for including parents in research, and she's been part of the Parents' Voice Project for several years. Welcome, Rebecca. Hello, and welcome. Hey, hello.
Hello.
I know that, hello. I'm so excited to sit back and enjoy the presentation that you've prepared for us about this work, because I know it is a passion project and it is something that is going to mean so much to so many professionals as well as parents. So I'm going to turn it over and let you start your presentation.
Great. Thanks, Jenna, for this introduction. And it's always a pleasure to be presenting to the Preemie Chat. And so I will share my slides. Perfect. So today's objective will be describing why neonatal follow-up of extremely preterm children is important. We'll also discuss limitations with how outcomes are currently reported in the literature. And we'll also explore parent-important outcomes following preterm birth. I will be starting, and then Rebecca will take over, and I will finish with the conclusion. So in Canada, 1 in 10 babies are born preterm before 37 weeks of gestational age. And about 1% are born extremely preterm, which would be under 28 weeks. And with advance in medical care, survival rate is now high. So we can see that now for babies born at 23 to 24 weeks who receive active care, it's somewhere around 60%. And for those born beyond 27 to 28 weeks, it's well above 90%. And these are data from the Canadian Neonatal Network. We also know that the third trimester is a critical period for body development that can influence long-term health. So when a premature baby is born anywhere between 22, 23 weeks to 37 weeks, his or her organs are still developing and they're still immature. And I'm thinking about the brain, the bones, the heart, the lungs. And these immature organs are exposed to factors such as sepsis, malnutrition, can also be lung injury from the mechanical ventilation or other treatments. And all those treatments are very important for survival, but they can also create some injury and alter how these organs will develop in the future. And that can predispose children born preterm to chronic health conditions, including neurodevelopmental issues. So this is why neonatal follow-up is important, to really monitor how the baby will be growing and also developing. So many neonatal follow-up clinics will be organized into programs that have two mandates, often a clinical one and often a research one at the same time. So on a clinical standpoint, clinics will be monitoring growth, health, and how the child is developing. And this is important because if we see any early signs that there's an issue with growth or development, we can then act upon that and refer, for example, to early intervention. So if in clinic I see a baby who is showing some signs of motor delay, I will refer for physical therapy to really improve functioning. It's also important to have neonatal follow-up to inform and help parents during their journey after the NICU. And in terms of long-term planning of resources, by knowing how preterm babies are evolving, what their needs are, it also helps knowing what are the needs in terms of healthcare, but also educational services. But very often at the same time, we'll be collecting outcome data, meaning like how the child is doing, to audit what's happening in the NICU. A lot of the intervention or the care we're doing on an ongoing basis, we need to make sure that there's no unanticipated problems over the long term. So what we do when we monitor the child's growth and development and health is really to make sure that in terms of long-term outcomes, there's no issues or any concerns to have related to some treatments that may have occurred in the NICU. We'll also use these data for some research, for some trial, and also this information that we collect in neonatal follow-up clinic, we bring it back to the obstetricians and the neonatologists who can then use this information to inform parents and guide them through their journey in the NICU. So what do I mean by collecting outcome data? So in Canada, what we do is we have a standardized follow-up visit at 24 months of corrected age. So for all the programs in Canada, we have pretty much the same way of assessing the child at 2 years corrected age. We'll do a neurological exam to identify any early signs of cerebral palsy. And if the child has cerebral palsy, we'll make a statement on the level of functioning using the gross motor function classification system. We'll also do assessment of the development using the Bailey scales, which will look at language, cognition, and motor function. We also look at hearing, often based on audiology report, or visual functioning based on ophthalmology or optometry report. And then what we do in research is we classify this child to know whether or not this child has neurodevelopmental impairment. And typically, and if you read the literature, that's how a lot of people do in research. They'll look at 4 things: cerebral palsy, development, hearing, and visual function, and they'll say, well, the child has none of them. But the child could also have what we call mild to moderate neurodevelopmental impairment. So that means that the child has cerebral palsy, but is able to move around and to walk without any aids like a walker or a wheelchair. That would be a gross motor function classification system of 1 or 2. A child who will have developmental delay, meaning that a typical score would be around 100. If the child is scoring below 85, we'll say that the child has some developmental delay. That would be also considered as mild to moderate neurodevelopmental impairment. And if the child has any sort of hearing impairment or visual impairment, he or she will also be considered to have mild to moderate NDI. And finally, we'll have the significant NDI, which is a child with cerebral palsy, but who needs some form of aids to be able to move around. A child who would have significant developmental delay would be scoring under 70, and then like someone who needs a hearing aids or has bilateral visual impairment. This is how we define it in Canada. Other countries will be a little bit more, will use maybe criteria which are more severe than what we're using here in Canada, limiting the significant to children who are not even able to use a walker on their own, who really need assistance by a third person. So that's a lot of definitions, but concretely, what does that mean? So actually, if I see this little boy in my clinic, while he has cerebral palsy, he needs a walker to be able to move around. So I would say that he has cerebral palsy with a gross motor function classification system of 3, as you can see in the graph. So that would be called significant neurodevelopmental impairment by a lot of research network in Canada, in the States, in Switzerland, etc. But when I look at this child, okay, maybe he needs some support to walk, but he looks actually pretty happy. He can do also many other things. So maybe, it's significant in motor-wise, but it doesn't tell the whole story of the child. And as a pediatrician, I know and knowing how this data can be used, I always feel a little bit, uncomfortable writing that this child has cerebral palsy and checking, this box in the research farm, because I'm always afraid how, people would interpret, this diagnosis. And that actually is at the basis of the Parents' Voice project. At some point, with a group of neonatologists, parents, we had this question, why have we chosen neurodevelopmental impairment as a measure of NICU success? Because right now, if you read the research, people will look at success or failure based on the presence or not of NDI. So the question really is, why has it become central to the way we counsel patients, families, and discuss prognosis with them? And do our answers really address the concerns and needs of parents of infants born preterm? So in brief, measuring outcomes of preterm birth is important, as I told you before, because this is how we'll be able to improve perinatal care. By knowing what's happening after, by understanding what influences development, this is how we can really improve ourselves. And this information is also crucial to inform parents. But for clinicians and researchers, a good outcome is disease-free survival, meaning survival without significant neurodevelopmental impairment. But how about parents? What for them is a good outcome? Actually, we never asked. So I will now turn the microphone to Rebecca for the rest.
Thanks, Mai. So before I talk about the Parents' Voice project, I want to discuss a little bit about what I'm doing here today and why I find this project so important and compelling. So I'm not a neonatologist or a pediatrician like Mai, but I'm the mother of a child who was born extremely preterm. My daughter Marin was born on September 21st, 2009, so she just turned 15, and she was born at 25 weeks and 5 days gestational age. She's a surviving twin. Her sister Lily died of an infection a week after their birth. Marin spent 4 months and 1 week in the hospital, and much of her course in the NICU was really difficult. She had the same bacterial infection as Lily. She needed a PDA ligation that was really risky because she was really unstable. She caught a fungal infection, developed severe bronchopulmonary dysplasia, and spent a lot of time on 100% oxygen or on a high-frequency ventilator. She was on a ventilator for a total of 7 weeks, required steroids, and came home with oxygen. So she was a really sick baby. A few weeks before we thought Maren might finally be discharged, she had a routine MRI, and we discovered that there was damage to her cerebellum that had been caused by a brain bleed that we didn't know about. And we had no idea what this meant for Maren's future. And turning to the research literature was really awful. I remember being curled up on our couch at home after having read some of the papers on the outcomes of children with cerebellar damage. And I was almost throwing up with the stress and fear because of how awful the outcomes were for these children. So as Maren got older, I tried to find information or research to help me understand how her prematurity would impact her. So what we all refer to as outcomes, and how this might impact us as a family. Can you turn the slide, Mai? So this is when I began to understand how limited the research into the outcomes of preterm children really is. So as Mai has already mentioned, there's a real focus in the follow-up literature with neurocognitive outcome. So as she mentioned, things like blindness, deafness, cerebral palsy, and IQ, but also things like learning disabilities and vision problems. And although I understand that these are absolutely important to document and analyze for many reasons, one of the problems with these measures is that they are reported as dichotomous. So either the child has it or they don't, without acknowledging that most of these outcomes are continuous and they fall within a range. And there's also very little research that examines what these neurocognitive outcomes actually mean for the quality of life and the day-to-day functioning of preterm children and their families. Maren had a lot of visits to the neonatology follow-up clinic at St. Justine in Montreal, where she was given tests such as the Bayley scales. And while these tests can identify children that may need more follow-up care, they actually have limited predictive value, and so they may not be relevant or helpful for parents. In fact, they might be very stressful. Most of the outcome measures that have been chosen for research have been done so by doctors and scientists without considering what parents or families consider important. So things like rehospitalization, respiratory health, feeding, sleep, and behavior issues are all things that can be impacted by prematurity and important to parents, but that are rarely studied in preterm populations. I also wanted to know how families cope with the stress and uncertainty of having a preterm child, but information was hard to find about this as well. Most of the research on outcomes was and still is very medicalized, and it's deficit-based because it focuses on all of the problems that preterm children as a group have with any sort of discussion or examination of their positive attributes. The voices of parents and preterm children have been largely absent in research, although this is slowly starting to change. And these voices are really, really important because they provide a critical counterpoint to deficit-based research, and they give us information about what is important to families and how they regard the impact of prematurity on their daily lives. So today, Maren is a happy, healthy 15-year-old. She had an early language delay and lots of respiratory problems when she was younger. She wears glasses and has strabismus on one eye. She has a math learning disability, and she has to work hard in school. Many of these things are quantifiable and probably relate to her prematurity and definitely relate to neurodevelopment. You'll notice that all of these things are negative, and this is certainly not how we think about Maren on a regular basis, but this is how she would probably be viewed in the follow-up research. She's also a really awesome teenager who plays the flute and piano. She swims, figure skates, does karate, and climbs. She's getting decent grades in a regular school because she works so hard. She has friends, she's independent and happy, and she considers herself like any other 15-year-old. So we consider Maren's outcome to be very good. But what do other parents think about how their own children are doing based on the values that are important to them? And how do these views align or not with the views of the medical professionals, who are the ones that are assessing and categorizing the outcomes of premature children? So this is where the Parents' Voice Project comes in. So the goal of this project is to engage parents in redefining important outcomes following preterm birth. And the team for this project consists of researchers and parents in Toronto, Vancouver, and Montreal. So the first part of the Parents' Voice Project aimed to compare parental views of neurodevelopmental impairment with a medical definition that's used by the Canadian Neonatal Follow-Up Network, or CNFUN. So parents were asked whether they felt their child was developing normally or had a mild, moderate, or severe developmental impairment. And parent responses were compared to their child's CNFUN developmental assessment that used current NDI definitions using Cohen's kappa statistic. So as you can see on this slide, these are the results of this part of the study. Now, the first important result is in the top left-hand corner, and that's that the concordance or the agreement between parent and CNFUN classification of NDI is very low, with a Cohen's kappa of 0.29. So if we look overall, 54% of children were considered to have no neurodevelopmental impairment by CN-FUN, whereas 68% of parents classified their child as having no NDI. When a child was classified as developing normally by CN-FUN, 83% of parents agreed with this. When a child was classified as having a mild or moderate NDI by CN-FUN, 40% of parents agreed. And when a child was classified as having a significant or severe neurodevelopmental impairment by CN-FUN, only 12% of parents agreed. So when we look at agreement of parental classification, parents view their children as being less impaired than scientists do. So the second project used vignettes to see how parents perceived the severity of disability, but without using medical terminology or diagnoses. So these vignettes were developed based on CN-FUN definitions of significant or severe NDI. And the survey was distributed to the parents of very preterm children nationally and internationally by parent foundations, such as the Canadian Premature Babies Foundation, using snowball sampling. So here is an example of one of the vignettes. So this vignette clearly describes a child his name is Jamie, with cerebral palsy, but without any visual, hearing, or intellectual problems, but again, without actually using those medicalized terms. Some of the vignettes also included composite outcomes. And after each vignette, parents were asked two questions. So if 0 is the worst possible health outcome and 10 is the best possible health, where do you think this child fits on the scale of 0 to 10? And does this child's case describe a severe health condition? So here are the results for question 2, which are shown as the percentage of participants who rate the vignette as a severe health condition. So the vignette, or the health condition that was rated by the fewest parents as being severe, involved a child with a cognitive delay based on the results of the 18-month Bailey test. The single outcome that parents rated as the most severe is a visual impairment, with almost 51% of parents seeing this as a severe health condition. The overall vignette that was rated by the most parents as representing a severe health condition involved a composite outcome of cerebral palsy and a language delay. And it's interesting to note that about 55.5% of parents rated this as a severe condition. The part of the Parents' Voice project that was carried out at St. Justine involved exploring the perspective of parents about the health of their premature baby, the impact that prematurity has had on their lives, and any decisional regrets that they may have had. So eligible parents were those of children that were seen at the CHU St. Justine Neonatal Follow-Up Clinic from July 2018 to July 2019, so for a year period. And these were children that were born at less than 29 weeks gestational age, who were aged between 18 months and 7 years at the time of their clinic visit. Parental perspective was measured using an open-ended questionnaire that was given in multiple formats, and the results were analyzed thematically by a multidisciplinary research team. So parents were generally representative of the Montreal population. For mothers, 63% self-reported as Caucasian, 25% as Black, and 12% as other, and 82% had at least a high school education. For fathers, 82% self-reported as Caucasian, 10% as Black, and 8% as other. And 87% of fathers had at least a high school education. The average gestational age of the children was 26.6 weeks, with a mean birth rate of 907 grams. And at their 18-month visit, 55% of the children were classified as having no neurodevelopmental impairment, 25% with a mild or moderate NDI, and 20% with severe NDI. So the first question that we asked was, if you could improve up to 2 things about your child's health and or development, what would they be? So 55% of parents identified their child's development as something that they would improve. And this included things like language and communication, behavior and emotional health, motor development and movement, and also cognitive and learning skills. 25% of parents said they would improve their child's respiratory health. 14% identified nutrition, feeding, and growth. And interestingly, 19% of parents explicitly said they wouldn't improve anything about their child's health and development. So the 2 graphs on this slide show the differences in parent responses based on their child's neurodevelopmental impairment status. So that's graph A at the top, and their child's age at the clinic visit, graph B at the bottom. So just to orient you, for graph A, the gray bars represent normal neurodevelopmental impairment, the white bars mild to moderate NDI, and the dark bars represent significant or severe NDI. So if we look at figure A, there are significant differences in the concerns of parents based on their child's NDI status in the areas of respiratory fragility, growth, and feeding. and also the number of parents that said they had no concerns. Just as an example, fewer parents of children with significant NDI indicated that they weren't concerned about anything. So this tells us that parents are fairly realistic about their concerns for their children. For graph B, the black bar represents children who are 18 months old at their clinic visit. Gray bar is 36 months old, the pattern bar 5 years old, and the white bar 7 years old. So in figure B, we can see that the older children were when their parents came to the clinic, the more their parents were concerned about their development, and the less they were concerned about things like respiratory issues and growth and feeding. So more parents of older children reported also having nothing that they would improve about their child's health. So this goes to show that as preterm children get older, the concerns of their parents about their development also change. Parents were then asked to choose whether prematurity had either a positive, negative, or both positive and negative impacts on their life or the life of their family. So 74% of parents said both, that their child's prematurity had positive and negative impacts. 19% said only positive impacts, and 7% of parents said that their child's preterm birth had only negative impacts on their life or the life of their family. They were then asked to provide some examples of the positive and negative impacts of their child's prematurity. So for positive impacts, parents identified an improved outlook on life, stronger family relationships, and seeing their child as a gift or a miracle. Negative impacts included parental stress and fear, a loss of family equilibrium, and also parental concerns about their child's development, as well as seeing their child as vulnerable. And finally, parents were asked, knowing what you know now, is there anything that you would have done differently? 54% of parents said that they would not have done anything differently regarding their child's birth or their stay in the NICU, that they did what they could and also what they were told to do. 35% of parents said they felt guilty or responsible for their child's birth. 28% of parents said they would have made different self-care decisions, and 20% said that they would have liked more information or knowledge about their parental role in the NICU. And parents of children with significant cranial ultrasound lesions were also more likely to say they would have made different self-care decisions and would have liked more knowledge about the role they could play in the NICU. So here are some examples that parents gave in response to what they would have done differently. So one set of parents said they would have listened to the nurses and gone to sleep because they spent 18 hours a day in the NICU near their twins. Another parent said they would have consulted a psychologist of the unit immediately instead of waiting 5 years after their child was born. Another set of parents said they would have liked to have known what parents can do earlier to get involved. And finally, a mother said that she would have pushed for better care and monitoring during pregnancy and when she thought that something was wrong because she felt as though she wasn't listened to when she was in labor, and she was. Thank you, and I'll turn the microphone back to Mai.
So once we completed this series of studies, what we did was really bring back the results to a community of people. So we had a series of workshops back in 21 and 22 to really discuss overall results with parents from the Canadian Premature Babies Foundation, neonatologists, also neonatal follow-up clinicians, and also experts in child development and members of the research team that may not be really necessarily involved in neonatal follow-up clinic. And the goal is really to say, okay, what does everything mean and what are the main conclusions? So if we summarize the results and the implications, we all agreed that parents and healthcare providers did not rate level of neurodevelopmental impairment the same way. Parents were more likely to describe their child development as not or less impaired than what CN Fund was doing. Parents also had a balanced perspective about their child's health and development. They recognized their child's happiness and positive personality independently of neurodevelopmental impairment status. They also expressed concerns mostly about development, but also physical health, including eating, breathing, and being often sick, which are things that maybe we don't look as much in follow-up. So the overall conclusion was that we should really revise how CN Fund is currently reporting on neurodevelopment, and also to integrate in our data collection other outcomes that matter to families. And so what we all agreed upon was that there were really priorities for our CN Fund data collection, which is right now, as I mentioned before, really looking at neurodevelopment. And the top 7 priorities, because there were a lot of priorities, were child quality of life and functioning. We should document a little bit more on respiratory health, on feeding, sleeping, behavior, the child's happiness, and also parental mental health. So in the next phase, what we're doing right now, we have the child bride parent voices, we could call it part 2, where we're really trying to implement patient-reported outcome measures in follow-up care of preterm children. So what are, in this new way of collecting the data, what we would like to do is really to introduce the WHO International Classification of Functioning, Disability, and Health framework, which does not just look at the deficits or how the organs are functioning, but have a more holistic approach looking at how the child is functioning through his activities or her activities and also participation in daily life. So currently what we're collecting in CN Fund are data related to body function and structure, like child growth, neurosensory function, a little bit of respiratory health, and we're doing the Bailey scales. But what we're going to do now is to include parent-reported measures with questionnaires or scales that have been validated and that look at child functioning and the child's quality of life. And what we realize is that the child's quality of life at such a young age is really also related to how this child is functioning through eating, through his breathing, etc. So with a group of experts, we've really searched the literature, looking at all the different questionnaires that had been validated. And with our consensus, we concluded that there were 3 questionnaires that could be of interest: the PEDICAT, the Pediatric Quality of Life Inventory Infant Scales, and About My Baby and Toddler. So currently what we're doing is really to narrow it down to only 2 questionnaires, because we don't want to to burden parents in follow-up, asking them tons of questionnaires. So we're asking input from parents in follow-up clinic and also to all the clinicians throughout the CN Fund to really get a sense of what makes sense to them, but what's also feasible. And these questionnaires would be able to really get a sense of functioning of the child and his or her quality of life. So that's about it. I think we went really quickly, but I think the most important part is really the conversation that we'd like to have with you guys after this presentation.
Thank you so much for walking us through the project and what you've been finding out. I think it's been really enlightening to get a deeper understanding of work that's being done that parents don't always know about. I'm wondering, Rebecca, if you could maybe talk a little bit about what you hope this project is going to mean for future parents like you in the NICU.
So my hope is that more and more, as Mai said, that when there's follow-up visits with families, that there are going to be other pieces of data that are collected. So for example, mostly about the child's functionality, how things are working for them. The 5 F's, I don't remember all of them, what they are, but family, functionality, fun, friends, and I'm missing the 5th one, but anyway, get the idea. So, I mean, as a parent, like I said, I understand that it's important for quality improvement and to see how different NICUs are doing to collect data about more medicalized outcomes. But I think, again, that those types of outcomes don't mean as much to parents as functionality does. Happiness, does my child have friends? Are they healthy? Are they sleeping properly? Are they eating properly? And I think that not just for families, that this is really important for medical professionals as well. So especially for people who work in NICUs, the doctors, nurses, respiratory therapists, everyone, they tend to see babies when they're at their sickest, when they're at their worst, and then they kind of never see these kids again. Mai does, because she gets to follow up and see how they're doing. But for a lot of medical professionals, I think they have a really untrue or sort of biased view of how the outcomes or how these kids are going to do when they're, 8, 10, 4, 15, 20 sort of thing. And so I think to collect a more balanced view again of these outcomes would really help medical professionals be like, oh wait, most of these kids are doing okay. Like they might have their challenges, like many non-preterm children do, but they're still doing really well. They're happy, they're in school, they're not sick all of the time, even if they're on a respirator for a long time, things like that. So I think it's really important for parents and families, but also it's important for the medical community to have that sort of research too, that view.
I'm wondering, Mai, if you want to chime in there about, how can we help healthcare professionals balance that need for information and sharing relevant information with parents with their word choice and keeping that sense of hope and perspective about the future?
Well, that starts with education, education of clinicians. And I think, it's really the way that medical training is made. We've been trained to look for deficits, and that's not just in pediatrics, like it's all throughout medicine, for adults, for elderly, we'll look at the problem. This is why we were trained. And I guess like the idea is if we find the problem, the deficit, we can cure it. But at some point we have to think, okay, what are we trying to change? Because some of the conditions, there's no cure for these conditions. So maybe the focus should be on functioning and quality of life. And so that's why I really like the World Health Organization model, which actually doesn't apply just for, children. It's really for everybody. And it really conceptualizes health as a state of well-being, physical well-being, emotional well-being, social well-being. And what they state in their definition that it's not the absence of disease. So what it means is, you can have a disease, you can have a condition, for example, but this should not, like the goal would be that even if you have this condition, you should be able to, to do your daily activity and to participate socially to the extent of, what you wish to do in your life. So for example, a child could have cerebral palsy, but if the child has proper support, and that can be support from a walker, that can be also adaptation in the physical environment, this child, will be able to participate, learn, and do, do what he or she wants to do. On the opposite way, you could have a child who doesn't have any medical condition, but yet this child is not functioning for any reason. It's not because the child doesn't have a diagnosis that we should ignore. We should still see, okay, what can we make as a health community, as an education, the school system to make this child function, even though this child doesn't have a diagnosis. So I think, focusing always on diagnosis is maybe we should slowly move away from that and really focus on how is this person functioning, regardless of whether there's a diagnosis or not. I think the diagnosis is useful for the doctors, maybe for the speech therapist or just the teacher to know, okay, what's the pathology behind. But after, it's not really going to be helpful to know what can I do to help this child. And to do that, you really need to analyze, okay, what makes this child unable to fully participate, fully function. And that's what, we're trying to move to with CNFA, not to just look at the body structure, but also to get the perspective of the parent on how the child is functioning, what's his quality of life. And that's regardless of whether or not we found a diagnosis or not.
I think the other thing that's important too, like one of the things that I found really interesting in the Parents' Voice Project was just, again, how the concerns of parents change as their children age, right? Which one would expect, because it's like that for every parent. But a lot of the outcome research that's done is done when children are very, very young, like 18 to 36 months, sometimes like kindergarten, school age. And I understand why. It's just really hard, I think, to follow kids as they get older. People move. It's harder. There's less and less participation and follow-up. But I think it's really important that as much as possible, there's more research that's done with preemie populations at different ages. because we know that, it's hard to prognosticate from information you get when a child is, 18 months old, sort of thing. So it's more interesting to look, maybe how they're doing when they're 10, when they start school, when they start high school, things like that. So I hope that that's going to change as well in the future.
I think that's a great point, and a perfect time to mention too one of our comments that we had during the presentation from Ashley, who is a grown preemie now, 20. She talks about what it's like to be able to find other preemies, to be able to talk about as an adult and what that means. And she mentions there that she really kind of related to some of Marin's story that you shared, Rebecca. And I think it's so powerful when we can have moments like this to talk about research that maybe is still focused on our infants, but that looks at this idea of what do they grow up to be, and to have grown preemies be able to join in the conversation is really wonderful. So thank you, Ashley, for sharing your thoughts.
Just to add to that, actually, Mai is involved. Thank you, Ashley. It's really cool to see your comments there. It's nice to hear from like the parents and also like premature children as they get older, because you always kind of want that crystal ball as a parent to sort of be like, what's my kid going to be like when they're 20 or 21? And anyway, but I know Mai is sort of tangentially involved in some research again that looks at like how the health of older preterm children are, because they tend to sort of fall off again because most of the interventions and the research is done when they're really little. Like Ashley is unusual in that she was followed till she was 16, but we know that there's the possibility like preterm children are more susceptible to certain things like bone density problems or kidney problems. It's not saying they all will, but they just have a higher likelihood. But a lot of that information isn't being given to parents or former preemies. So that's something that's really important too, that sort of communication, that sort of outcome piece is making sure that children who were born preterm know that it's important for them to be followed by a doctor when they're older, for their parents to know that they shouldn't smoke, for example, and no one should smoke, but especially former preemies shouldn't smoke and things like that. So it's that's something else that is important too.
Yeah, and a lot has to do with raising awareness to parents, also to clinicians, and to educators. And what I really learned from the Parents' Voice Project, it's really this partnership with the Canadian Premature Babies Foundation, because we really had, this conversation, and really at the goal, we all have the same, we all aim for the same thing, for the child to be doing, the most optimal way. And, I could do my research on my side, but then I would have a completely different interpretation of the results. And at the same time, I think, the parents can have the question, but they will maybe not know how to put it into a research question or how to validate it scientifically. So this, conversation that we have, I think it's really critical, because both, we bring different perspective, and I really think that together we can make the field move further. And just as an example, I was presenting these results to neonatologists and clinicians. And, I think the first response is when you try to bring change, people don't want to change. But I remember at that conference, my biggest support was actually from some parents who stood up and said, what she's saying is true. This is not, this pediatrician saying something that, this is the Parents' Voice Project, and we all agree, and this is not just, she's the person who represents with Rebecca, but it's actually the voices of many parents. So I think if we bring our voices together, this is how things will change. And I think clinicians, when it comes from the parents, it's really powerful. And to the same extent that if, a patient, an individual with a lived experience wants to say something and it's supported with science, and the scientific result just makes even more sense if it's also brought forward by people with lived experience.
I have one final question for both of you before we go. I'm wondering if you could just share a little bit about where you see the next steps in this. What comes next for the project and for this push overall?
Yeah, so we'll implement those questionnaires, but requiring some change in clinic to, do those. Well, we used to have other questionnaires that people were so used to, but those questionnaires, once again, are very deficit based. Is, can your child do this? So it's really to change the mentality in clinic and get, another way to ask questions. And the questionnaire we've picked, as I said, with clinicians, researchers, parents, and now we're just trying to see, but that's a limited group. We were maybe like 15, not limited group, like 15, 18 deciding on those. Now we're bringing this to a broader group and also to parents, because maybe, they'll say, okay, I really like this idea of function, but you're not going to ask me to, complete this 15-minute questionnaire in clinic because, this is not helping me. So we really need to adapt, because I think, it's really important to include in research, but we also think that, what our hope is that these questionnaires can also help us in clinic address, parents' concern. But for that, it does take some changes, both from parents, both from clinicians, and this is what we're working on. So we're focusing on function and quality of life, although there were other, several priorities, because I think, we have to make one change at a time. But if we can make it, at least, the goal is to make sure in clinic that we're addressing the parents' concern, but also when we'll be reporting in research, we also have measure that not, that don't tell just about, cerebral palsy or Bailey scores, but also parent, the parent's perspective using, validated skills. So.
For me, I think exactly what Mai said too, and also knowledge translation, I think is really important, both for medical professionals and for parents. So there's already been a lot of publications that have come like over the years from the Parents' Voice Project, from the different parts of the studies, which I think is important because like I was mentioning, we have to, it's, it's not gatekeeping exactly, but it's the medical professionals that are ones that are meeting with children, that are, classifying kids, that are doing the research, etc. So it's important that the results of, this project be transmitted to them, but it's also important that parents know about this. And I know CPBF has tried to do that sort of knowledge translation piece as well for parents. And I'd like parents to be able to be more to be able to advocate more knowing this for their kids at the clinic. So to be able to say, to know what other parents are concerned about, for example, to know what other parents are happy about their children, so that they have that information when they do go to a follow-up clinic or when they go to their pediatrician. So a lot of parents, and again, it's not saying we should scare parents, but there are a lot of, again, outcomes that aren't discussed much in the literature. So like sleeping and feeding and things like that, that a lot of parents are like, what's going on with my child? When it's sort of a commonly known outcome of prematurity, they just don't realize that because no one's told them. So I think that would help parents know that, oh, wait, this is something I should be discussing with my doctor. This isn't, to see what we can do sort of thing. So I think that that's important too, the translating this information to doctors and to parents.
That's a great point. And we did put a link in the comments there as well to the Canadian Preemies website with a link specifically talking about the Parents' Voices Project for people that want to be able to find out more about it and start that process of sharing knowledge on their own. So I would like to thank you both so much for taking the time to share your knowledge with us here today. I know this is a very important step in the process as well. And so I appreciate all the time and effort that you both put into it and the personal effort to share your stories. Thank you.
Thank you so much.
Thank you. And I want to thank all of you who have joined us today and have been sharing in the comments and watching. We definitely appreciate your attention and your time, and thank you all for sharing your thoughts. My guests today were Preemie parents, and researcher Rebecca Pearce and Dr. Mai Luu, a pediatrician, researcher, and neonatal follow-up expert. And as I said, you can find more about the project on our website at CanadianPreemies.org. And if you look for the CN Fund, the Parents' Voices Project, you'll find information there, and it's in the comments as well. And if you would like to go back and watch the presentation again, if you know someone that you think should watch this and learn from it, you can find this video and all of our various other Preemie chats on our website, our YouTube channel, our social media. So please do take some time to share this with those you think should see it. Of course, we will be back here next week as well. And I'd also like to take a moment to thank our series sponsor, AstraZeneca, for their ongoing support of our educational programs, as well as our partners with the Canadian Association of Neonatal Nurses and Thuy Care. I hope you have a wonderful weekend, and we'll see you back here next week.